Welcome to the OR Today webinar series. We are excited to have over 110 pre-registered attendees for today's webinar. Before we begin, let's give away some swag. The second annual OR Today Live Surgical Conference will be held August 28th through the 30th in Chicago, Illinois. We have an OR Today Live tote bag to give away to the first attendee who can tell me what is the name of the tallest building in Chicago. Use the question feature on our webinar dashboard to answer now. While you're answering, I want to remind you today's webinar has been approved for 1 CE contact hour. To obtain your certificate, you must complete the post-webinar survey, which will appear immediately on your computer screen at the end of today's call. If you do not receive the survey, please email us at webinar@mdpublishing.com. Okay, and the winner of our OR Today Live tote bag is Jana Preet. Jana, congratulations. The correct answer was the Willis Tower, formerly known as the Sears Tower. Registration is open for the OR Today Live Surgical Conference. Details are online at ortodaylive.com. Our presenter today is Joby Hyman, the Clinical Category Director of Supply Chain Management at St. Luke's Healthcare in Boise, Idaho. He is an experienced and dynamic nursing leader. He says working in managing and developing new models for the hybrid operating room has been the most exciting addition to his skill set to date. Joby, you may begin whenever you are ready.
Thanks so much, Kristen. Good morning, afternoon to all who are in attendance. I'm very excited to do this presentation today. This was done previously at the OR Today Live first OR Today Live conference back in Las Vegas. So those of you who are attending in Chicago will have a great time if you attend. I've been working with and around the hybrid OR for approximately 5 years and find it a super exciting space. And today, obviously, I want to talk to you about the education and staffing within that area. A lot of folks ask, what is hybrid? So hybrid can be a multitude of things. We know of hybrid cars, which are part battery, part gas-powered. So what is hybrid? It is not this. iRobot was a great movie, and people often think of this when they think hybrid. But let's explore this space a little bit more. For those of you who are familiar with hybrid labs, I hope this looks similar. This is a ceiling-mounted unit, and the next few slides will show different configuration of hybrid labs within different facilities. This is a floor-mounted unit, and depending on your facility, your layout, your structure, or if you're doing new construction, there are benefits and disadvantages to having either a ceiling or floor-mounted unit, and you want to discuss that with your physicians and construction staff as you go through the process. This is a robotic arm, and this is a unit that I've used. And the tabletop here is a hybrid tabletop, which is offered in many labs, so you can use the lab for not only interventional procedures, but also for normal open procedures, which I think is the best way to do a hybrid lab these days. In the past, that has not been the case. They have been strictly interventional labs, so to try to do strictly open cases in a hybrid room was not very useful. So who uses hybrid? Obviously, cardiology will. TAVR procedures are on the rise in a lot of different centers throughout the country, and it is a very exciting place to know that we can replace the aortic valve through a catheter technique, and a lot of places are not even opening the groins anymore. They're doing totally percutaneous intervention there, and it's very exciting. The next group, obviously, is cardiovascular surgery. They're involved in TAVR procedures, and we'll be moving into more spaces as more technology comes out, but cardiovascular surgery can use this in many different multitudes, whether it be lead extractions from the EP physicians, the TAVR procedures, or minimally invasive valve replacements. The EP lab physicians will use the hybrid spaces. Here you can see that mobile C-arm, and mobile C-arm doesn't give us the resolution nor the imaging that is required in a lot of these cases, so that's why the hybrid lab is so important in that space. Interventional radiology is another great place, using the technologies that the hybrid lab offers you to help with stroke victims or other procedures is awesome. And then obviously vascular surgery. The modeling that can be done within a hybrid lab, and knowing that you can do a true hybrid procedure where you're doing part interventional, part open work within the space is something that has never been done except with C-arm. And like we said, the technology and resolution and imaging that you can get with these new labs is phenomenal. So who works in the hybrid room or hybrid OR? Obviously nurses, because we know within all surgery spaces, RNs are integral to patient care. Certified scrub technologists are also part of the mainstay and normal staffing patterns that we see within any OR. RCIS, I think, is a new concept for a lot of folks within the OR space or traditional OR space, because these professionals typically work within the cath lab environment, and it's in a lot of places they don't cross paths. And then radiology technologists who have the credential and skill set that they have, and we typically in the OR setting only see these folks when we're doing C-arm or getting flat plate x-ray. But within the hybrid space, all four of these individuals and professionals can work as a hybrid team, and I like using that term as team because they can all play a role in making sure our patients are safe, they are under anesthesia for the least amount of time possible, and can create successful outcomes for our patients. So the skills that are required for these outstanding outcomes, all folks need to know anatomy, and I think with those previous four disciplines, there is extensive education within the anatomy space. But with working in the hybrid OR, we need to look at the procedures that we are doing within those spaces and make sure that all the folks working on the team have a very intimate knowledge of the anatomy with the procedures that we're working on. Hemodynamic monitoring is another piece where you're going to have to do these pieces of the puzzle, whether you're using anesthesia or not, because obviously those things will give us different case outcomes. Sedation is another skill set that is definitely required for folks that work within this space, because not all cases are done under anesthesia. We may be providing moderate sedation within these cases and is best for the patient. So knowing how to do sedation, how to screen for cases that we're using sedation, and then post-care for sedation is necessary. And then you definitely have to have a dynamic thought process. You have to have those critical thinking skills, because things within the hybrid OR happen at a much different pace and at a much different level than they do in a traditional OR setting or even cath lab setting. Specialty equipment. We're used to this within the traditional OR setting, but bringing in the radiology components, the imaging components, the hemodynamic monitoring components into the operating room and having the team responsible for these is another bonus or add-on that we are not traditionally looking at. So do you know what you're doing? So the education piece, RNs and surgical scrub technologists always are comfortable within the OR setting. Bringing in professionals from the outside, they don't always understand aseptic or sterile technique, and those education pieces really need to be added, as well as the RN and the certified scrub tech don't have the interventional thought process or interventional skills, so the education provided to each of these team members is going to be targeted and specialized in as much as each team member brings their specialty. And that's what we have found has brought the most cohesiveness to the team. People who wanted to join the team, learning from each other and being able to support each other in their strengths and their opportunities to grow and having the team build upon that is really what has given our organization and the teams that I have worked on the most strength and provided really, really exceptional care. Experience. Experience, we all know, can never be substituted for. The more experience you have within a specialty or a subspecialty is going to lead you to the ability to teach, the ability to learn, and the ability to give input and feedback to the members of the team and physicians to make sure that our patients receive the best outcomes. And then skill set. If you have skills that your other team members don't, you're a value-added member of the team. If you lack those skills, having someone else who does have that skill set and being open to those comments and those suggestions and constructive feedback from the other team members allows you to gain those skills so everyone performs at a very high level. And then obviously checking off competencies. We've had competency checklists for each discipline because we know that each come to the team with varied skills, varied experience, various education. So to make sure that all of our folks and team members work at a high level, the competencies are worked on often to make sure that the team works as a cohesive unit. It is not unlike, I'm not sure how many of you have been within a cath lab when a STEMI is going on, a ST elevation myocardial infarction, but watching one of those teams work in those time-sensitive situations builds a level of confidence on the team, and all of those skills and that teamwork within the hybrid OR is very, very necessary and important. So obviously gaining that expertise, because bringing proceduralists and team members together on a common page can be trying and taxing. All of our physicians are very comfortable with the team that they work with on a day in and day out basis, but bringing in new members to that team where the physicians and surgeons and interventionalists are not used to working with those individuals and their skill sets can sometimes be trying. So getting buy-in from our doctors and getting them on board with how we feel that this team should move forward is obviously of the most importance. The proceduralists know their procedures and how they're going to do their procedures. They've been to training courses, they've been proctored by other physicians to be able to provide the level of care and the procedures that they're going to do within our spaces. They also know that they work with RNs, or they work with CSTs, or they work with cath lab folks, and they're used to working with these people and letting them know and putting them in a space where they can get to know that the proper outcome is going to come from including these other people on the team is essential and vital. Making sure that your folks and your organization is accepting of having your team members orient to other areas. So where those skills and that expertise and that experience is low, surgery RNs not understanding or not being familiar with the interventional space, making sure that they can go to the cath lab or they can go to interventional radiology or special procedures so they can be familiar with the radiological equipment. They can be familiar with guide wires and catheters, stents, or sometimes things that don't happen in the operating room, and not having that ability to get those experiences within the OR and go into those other spaces is vitally important. And where a lot of our team members are able to also gain the respect and comfort level with the proceduralists, because if we have cardiologists, interventional cardiologists working within the hybrid lab and they're not familiar with the staff that work in that lab, having the staff go to the cath lab and at least hang out and be able to learn how that physician works and what he's expecting and how he communicates adds another layer of ease and simplification to the team and the procedure. Charting is varied by institution. I have always advocated for one chart, one record, because when you have two documentation systems, the cath lab has a specific documentation system, as some of you know, And the OR definitely has a different documentation system from the cath lab, because within the cath lab space or the interventional space, we chart each time a wire goes in, a wire goes out, and any subsequent material, whether it's an implant or not, we track that within the hemodynamic monitoring system, and that hemodynamic monitoring piece goes into the patient record within the interventional space. In the OR space, traditional open OR space, we document the way we do, make sure our outcomes happen, make sure we meet our nursing goals, and all the requirements there. Both of those systems have to merge. You have to have all of your typical operating room documentation, but you also have to have the interventional documentation system. So having the the team members familiar with the hemodynamic monitoring system, if they are not familiar with that, is very important. And then making sure that the folks who are used to working in the interventional space fill out the proper parts of the chart for the operating room records, so we can have one record is essential. Having that one record, you don't have conflicts. You don't have to have folks communicating about times. You don't have to have folks communicating back and forth about implants and so forth and so on. So if you can have one person that can record the whole case, that frees up essentially a team member to help with staff in the room, or help scrub in and help out, or potentially just decrease your staffing by one, which we all know finding staff and having staff available for other cases is not very easy in today's economic and labor market. Who benefits from the hybrid OR? These questions will be asked by administrators, by leaders throughout the organization when physicians are asking for a hybrid OR space, and it's always incumbent upon the leaders within the operations side of the puzzle to show, hey, hybrid OR is important, is beneficial, and the outcomes that come from that are beneficial. So patients are going to benefit. They're going to be able to have minimally invasive procedures, which we know minimally invasive procedures lead to less surgical site infections, lead to shorter lengths of stays, lead to increased recovery times. Folks are able to ambulate, or able to be discharged, or able to return to normal function and activity once they're discharged, and patient satisfaction goes up. So patients 100% benefit from a hybrid OR procedure. Staff benefit because they're able to learn new skills. I know throughout my career I have been always wanting to learn and be on the cutting edge of what's going on within healthcare, what's going on the cutting edge within interventional radiology, or the catheterization lab, or the OR, and this is where the hybrid OR is. Staff are able to learn new skills, are able to work within environments that they haven't up to that point, and staff satisfaction goes up because they are part of a highly dynamic team that works together, and it actually forms a small family within the larger family of either the operating room or the interventional space, depending on where your hybrid OR will live. So staff see a lot of benefits and satisfaction from hybrid ORs. And then obviously the healthcare facility can generate more revenue, can receive higher patient satisfaction scores, and can offer procedures that others in the region or area cannot, increasing their marketability and hopefully increasing dollars to the bottom line for the organization to continue to invest in staff and infrastructure for the healthcare facility. With that, that is the end of my presentation. I hope there are questions, and I am open for any and all of those.
Hi, Joby. Thank you for your presentation. We do have a question or two that have come in, but we want to remind anyone out in the audience that if you do have additional questions, go ahead and submit them now using the questions feature on your dashboard. Meanwhile, one of the first ones that came in, how do you orient your cardiologist to the OR sterile technique compared to normal cath lab atmosphere? Let me read that again for you. How do you orient your cardiologist to the OR sterile technique compared to normal cath lab atmosphere?
So within the facilities that we've worked in, that typically happens when you have cardiovascular surgeons or typically cardiovascular surgeons or surgeons who are used to working in the main OR proper and cardiologists working together. They start those conversations early on because the general rule is the technique that happens outside of the OR is not as acceptable within the OR. And the physicians, even though they have their own rights, they know they're going into a new space, and they really are able to the physicians I've worked with are able to open up their ears and really want to be a piece of the team, so are open to that constructive criticism. I've always tried to offer suggestion as opposed to, well, that's not the way we do it here, because we always know that that brings up people's defense mechanisms, but allowing them to say, hey, you know, I noticed that you did this, that, and the other, and kind of letting them know. Within our space, we call out contamination on a regular basis, and it's not a call out or a negative to you. It's this is how we protect our patient, and they're usually and almost always accepting of that from the staff members.
Okay, we have another one that's come in here, Joby. Let me copy that out of the dashboard in one moment.
In working, and I'm just going to fill in a little bit of space here, physicians all want to work within the hybrid space and work on these procedures because it's a passion of theirs, and in laying out the groundwork ahead of time, it really helps the physicians, and it helps the staff to have those little bitty impromptu meetings, or the leader of the group to speak with the physicians to let them know or ask them what they think they'll be needing and how those things will go. And imparting those ground expectations in the beginning really helps, letting everybody in the team know we're here to work together, we're in this together, we're all here to learn, and allowing us to do that really puts all of that defense mechanism down, and really truly being able to speak to each other as professionals takes away a lot of that anxiety.
Great. So the next question we have that came in, are there other disciplines except cardiology and vascular where hybrid procedures could bring advantages?
Oh, absolutely. Stroke patients, so interventional radiology or radiology. Anytime you're coiling an aneurysm in the brain or after a clot in the brain and have to do a stroke, if you're able to be in a hybrid space and a neurosurgeon may have to come in and do burr holes or any of those things for something that's going on in the brain, that's another great place where the hybrid OR is highly useful. And if you think of a hybrid OR in the true sense of it, it can be used as an open room. So if you don't have procedures booked in that room and something comes through, or you can schedule it depending on how heavy or light your load is within that for utilization of your rooms, you can do appies and hernias and those kinds of things. Smaller cases, I think, are able to be kind of an overflow room. So when those emergencies come through, or any of the cases where you definitely need the hybrid lab, that's where your form and function comes in within the hybrid space.
Very good, thank you. Another question has come in. You mentioned there are advantages and disadvantages to floor or ceiling mounted equipment. Please speak to what those are.
So ceiling mounted systems, if you're trying to retrofit a room, so if you have a room that has already been built and you're using, and you try to put in a ceiling mounted, sometimes the structure of the ceiling will not support that type of mounting. The disadvantage of that also is lights. So when you're trying to position surgical lights for open cases, because of the track in the ceiling, you can only get surgical lights in specific positions, so your lighting that we're used to in a normal main OR setting isn't as accommodating. So that's the negatives of the ceiling mount. The advantage of the ceiling mount, as we all know, floor space is at a premium because of all of the equipment and things that we need in the room. So it gives you that ability. You don't have a fixed unit. You can move your anesthesia machine in any configuration you need to. You can put your ultrasound machine in any configuration you need to. So you're able to get closer to the bed because you don't have anything obstructing you. It's all from the ceiling. So it kind of likens us to the move from floor-mounted ESU machines and suction to boom rooms that have booms, or what they consider laparoscopic rooms, where all of that equipment is up off the floor. The disadvantages of a floor-mounted system, I kind of spoke to. With a floor-mounted system, you're kind of hemmed in or caged in as far as where your anesthesia machine can go without special accommodations, where you need to place your ultrasound machine, where you may need to put your TEE machine. So that's some of the benefits of the disadvantages of that. The benefits of a floor-mounted system is you know exactly where those things are going to be located, and that's for staff knowing how to set up a room, where things are going to go, how that flow goes, and the limitations of the room and the arm all lead to being able to get everything in the proper place so you can get your procedure done in the correct amount of time and with the least amount of input from the surgeon pre-case.
Okay, I think we have a follow-up question to that question.
Okay.
For open surgery, isn't a surgical table needed and as a result already considered in the planning phase?
So are they speaking to, so a regular OR table? I guess I'm not totally understanding the question. Can you read it again, Kristen?
Sure. For open surgery, isn't a surgical table needed and as a result already considered in the planning phase? Maybe it was in reference to the surgical mounts we had in the previous question. I'm not sure.
Okay, so there are some in previous. So depending on how your room is set up, if it's new construction, old construction, and the type of units that you have in your hybrid OR, the newest iteration of that is to do interventional procedures. You have to have a fixed table because of the mapping and all of the technology that goes into mapping out and getting 3D images for your procedures. So that table needs to be mounted. We are used to, in the main OR, moving surgical tables and those being able to be moved within the room. And that's not, you can't utilize that type of function in a hybrid lab unless you bring in a separate table. So you would then have two tables in a hybrid room. So what they've come out with now is you still have that fixed base, but there is a open surgical top that can be replaced on a normal interventional table base, so you can do open surgery with a standard table that has side rails that you can clamp retractors to or supports. So that would be in the planning phase, and that would have to be baked into your project cost or budget for having a hybrid top table for your hybrid room.
Okay, I hope that answers the question. The next one we have here is, I hear the concentration on vascular access cases. What about hybrid OR room use for craniotomy or orthopedic cases?
So our facility is embarking upon an expansion over the next 5 to 7 years, where we will have 2 hybrid labs. One will be dedicated to cardiovascular, vascular, and thoracic surgery, and the other will be dedicated to neurosurgery and interventional radiology. So within those 2 spaces, within those 2 labs, obviously we will be able to provide any case that will come through, And within the orthopedic area, you can definitely utilize the hybrid technology. I am not aware, just because within the spaces I've worked in recently, we haven't had any orthopedic work done, but those other areas of surgery definitely can benefit from the hybrid lab. Anytime you need imaging, it won't be the same it wouldn't be as utilized within the ORIF space, but I could see it used with total joints as a hybrid piece there. I can see that being a piece of the puzzle, but neurosurgery for sure. We will have a neurosurgery hybrid lab, and that form and function fits extremely nicely within the neurosurgery space.
Very good. The next question we have here is, please describe staffing ratios and other detailed information of staffing a hybrid OR room.
So it all depends on, obviously, the case. The model that I like and have seen that works the best, form and function-wise, would be, as we all know, we have an RN. And I don't like using roles necessarily, because other than medications and things that are inhibited by license, I try to stay away from. I try to get folks to not think about that, because I want all team members to be able to work to their full capacity, which is really one of the bonuses of having a hybrid team. So your RN is the only one who can give, depending on your facility. So so I'll speak about sedation first. Within our organization, in the cath lab, folks who have the credential of RCIS can give sedation in the cath lab space. We have run that over into our hybrid lab, so if sedation needs to be given, it can be given by an RN or a person credentialed with an RCIS credential. The only an RN is needed anytime a patient is in the room, because that is who provides the level of care. As far as documentation, running of equipment, scrubbing in for cases, any of the folks that work within the hybrid space are able to perform those functions. Anyone can open supplies to the back table, anyone can run and get supplies, anyone can document, and by allowing team members to know that the only limitation to their form or function or role is based off of their credentialing or licensure within the state that they practice, is the only limitation that the hybrid team would put on them. Within California, there is a fluoro license that needs to be obtained to run the fluoro equipment, so physicians have that, and then typically it's only radiology technologists that are able to perform those functions. So within that space, you would probably have an added individual unless you can combine some of these. So what I like to do is my surgical technologists, I like them to know how to run the hemodynamic monitoring equipment. Obviously, they are already skilled and know about surgery and open technique and cut downs and in performing surgery. But I want my RCIS, I have my RCISs, I have my radiology technologists that have come to the hybrid team to learn those skills in how to scrub a case appropriately, to know instrumentation, to know how to pass instruments, to assist physicians and do cases where a scrub tech may be off that day. They perform all of those functions in that space. So that's the crux of it for me. The amount of training and ability to get those proficiencies and competencies checked off is individualized, obviously, but I work with all of my team members to make sure that they are able to function in all of those roles. So typically it's one RN. I will have a scrub individual. I will have a person monitoring. If it's a TAVR, we have a runner, just because we don't keep all of the supplies in the hybrid lab. So our cath lab happens to be right across the hall, so I'll have one person as a runner or a coordinator, just to coordinate all of the things and team in the room. So it's typically 4 or 5 people for a TAVR procedure. For interventional radiology type cases, neurosurgery type cases, it's the same. You have a nurse caring for the patient. You would have anesthesia taking care of the patient. From the anesthesia perspective, you would have a monitoring person, you would have a scrub person, and then someone available to run. They don't necessarily need to be in the room, but someone who is familiar enough with the supplies and procedure to be able to get those things for your staff. Mobile carts are extremely useful in that your hybrid lab can then be transformed from a vascular type case or a cardiovascular type case or an interventional radiology type case or a neurosurgery type case. It helps to provide more form and functionality for the hybrid lab as opposed to having fixed furniture in the room, which then limits your capability and functionality.
Very good. The next question we have here, is there a minimum size these rooms should be in terms of square footage?
Absolutely. From my own experience, I think if you go any less than 1,000 square feet, you really are hemming yourself in. If you don't have fixed furniture, as I was speaking to before, and you have mobile carts, you can probably get down to about the 900 square foot range. But the other consideration that you need to have with these rooms is you have to have a control room. So you have to have a room that is separate, that holds all the monitoring equipment and all of the radiology syncing equipment, potentially intravascular ultrasound and other ultrasound. So so if you build a room that is 900 square feet, excuse me, and then you have to take up about 100 square feet or so with the control room, the ability to walk around and move within a sterile environment in less than that is very much compromised.
Okay, one attendee has asked, do you have any examples of the competency forms that you could share with us?
I can absolutely do that. If they want to send me an email, I can get those out to them.
Great. The next question, probably the last one that we'll get to today. Have you found the AORN guidelines to be supportive when cath lab docs push back on topics of aseptic technique and sterile attire?
I have not, because the cardiologists don't work in the AORN realm, and I try not to rely on AORN or any necessarily governing body that doesn't address the specialties that they come from. Cardiologists do deal in a world, so with this being hybrid, surgery staff need to understand the different environments. With truly percutaneous procedures, just poking a needle into someone's artery or vein is a totally different mindset than what we're used to with open wounds and having tissue and those things open. So if you're doing truly percutaneous procedures within the cath lab and other spaces, they don't have surgical site infections. They don't have the complications that we see in surgery, that the reason that we go to the sterile lengths that we do, and they don't have negative outcomes. So trying to say, well, AORN recommends, automatically puts them on the defensive. All the conversations I try to have are to get rid of all of the defenses and come at the conversation from their point of view. So the attire piece I am 100% supportive of and always talk to, and we're very fortunate that our physicians and cardiologists, when they come into the OR space, know that, hey, wearing the appropriate attire, because the reason we're doing this in the hybrid lab is there is the potential that this case will go open, and this is the environment that will happen. So we operate with these thought processes. And talking about sterile technique, because they deal a lot in aseptic technique, but the sterile technique piece of it is the same conversation. We're not looking at what's going to happen here, but what's going to happen in the event, and the reason that we're doing this case within the hybrid lab. So we are trying to create a sterile environment and allowing our patient to have that and work toward preventing any potential contamination in the event that we have to go open, is where I come from. Because working in the hybrid space, that's the whole reason we're working in the hybrid space, is to hedge our bets that if something were to happen, we can take care of that. And having to figure out if something is potentially contaminated or not within that space takes time away from the physician and time away from the patient. So if we treat everything as sterile, then if that eventuality were to happen, we are able to be 100% certain that everything is sterile, and we can provide for our patient in a manner that we would within the OR, within the surgical or open OR environment.
Great. Thank you, Joby. We appreciate your presentation today. We're going to go ahead and conclude today's call with a reminder that one lucky attendee will win lunch for their entire department. Details are included in the post-webinar survey, which will appear on your screen shortly. If you do not see the survey, please email us at webinar@mdpublishing.com. A reminder, you must complete the survey to obtain your certificate of attendance. Thanks again, Joby, and we hope to see everybody in Chicago this August at OR Today Live.
Thanks, Kristen. Everybody have a great day. Thanks so much.